Thanks so much. I really appreciate it. Thank you to Snoasis for having me. Looking forward to this. These are going to be talks on some products that have really changed my practice and how I do things. And so I'm very excited to be able to show that to you. What we're looking at is really going to be talking a lot about space and stability when it comes to using materials to be able to regenerate deficient ridges. Homlei Wang published this famous article on the past principle, and the past principle was really about primary closure, angiogenesis, space, and stability of the graft membrane complex in order to be able to regenerate when you have a ridge deficiency for the purpose of implant placement. And it's a very well-known article, and all very, very important principles, and what I'm going to do is just focus on these two. One of them is related to this, and this little happy face membrane, as people know it, really does a lot on its own. It's more than just a happy face, and it's really become somewhat like hot sauce. This is my personal favorite, or duct tape, or even Windex, has that reputation for being a cure-all. And it really is. There are 1,000 different uses. I could go on for a couple of hours talking about the different ways that I use Bio-Exclude alone. But what we're going to do is show how it's used in combination with some other materials. Now, what is Bio-Exclude? It's the Amnion-Chorion layers of the amniotic sac, just without the epithelium and without that middle intermediate layer. And so it comes with a lot of growth factors. But like everything in life has its pros and cons. Pros of Bio-Exclude are related to its versatility. It has an 8 to 12 week barrier layer. It limits excess inflammation. Beta defensins, everybody knows about beta defensins, I'm sure, and has over 200 growth factors inside of it. That's way more than any other material that we use. Obviously, it has its cons. It does. If anybody has used it, you found that it folds up on itself, and you found that it's somewhat difficult to handle, whether it's dry or wet. You have to play with it in order to get it to do exactly what you want it to do. So, what's it for? Do we use it for? Is it me or is the microphone going in and out? The microphone seems to be going in and out. We'll keep going. Let me know if it's a problem. So, if we look at what is it good for, this is a bread and butter case. Eleanor, who is having a maxillary molar get extracted, do a simple ridge preservation bone graft, and use a Bio-Exclude membrane as the barrier in order to contain the graft. And it really is a minimally invasive procedure. Tuck it under the palatal and buccal aspects, and wait. This is a technique that's well published, even with Bio-Exclude, and we can see how it heals at 16 weeks. Now, normally at 16 days, these sites don't quite look that nice. With Bio-Exclude, there's no question I see it looking a little bit nicer. And to me, that looks like that's been healing for, a month or so. And it certainly doesn't look like something that's healing only for 16 days. Let's look at Nancy. Nancy's a case where there's a apical lesion on tooth number 9 and implant number 10 has a bone deficiency. So you do a combination procedure with the endodontist who comes to my office from within the building, and he comes up, does an apico on number 9. I do not do apicos, and I just treat that implant surface, clean it up, place bone graft, and place a Bio-Exclude membrane. to be able to contain the graft. And if you look at after suture, look at the healing of this one is 11 days. And the healing at 11 days using BioXclude is just superior in my hands to not using BioXclude. So here's another case of looking at an immediate implant where place your implant of choice, place your bone graft of choice. This is standard stuff that everybody likes to do. And if you've heard of the poncho technique, you can do it with PRF. You can do it with a BioXclude. I do feel bad going right through the middle of the happy face, but with a 12 by 12 BioXclude, it's kind of the only way you can go. And it's really just to contain that graft material, place a healing abutment. This is a one-stage procedure. I'm not having to do an uncovery procedure. This is one stage with the healing abutment. Or, I'm sure this never happened to you guys, only to me, but it's sinus perforation on extraction of tooth number 15. You can see that perf. And this is, I'm using a microscope to be able to look inside, so although it looks like it's on the lower arch, it's upper arch. Now there's no question, placing a BioXclude in there is somewhat challenging. When it's dry, it's still challenging. It folds on itself, it doesn't quite conform to the area. But then when it's wet, it conforms completely and serves to be able to contain that graft. And even looking at the post-op CBCT, I can see how my graft is completely contained even though I had that perforation. And what's this? This is something new. So if BioXclude is able to be used for all of those things, this is the Laminar Allograft. This is a laminar plate that is resistant to pressure. It's easily trimmed with scissors, anything you want. It's demineralized, which is very important when you look at your post-operative CBCTs, your healing CBCTs. Know that that's not counting that membrane, even though it has a thickness to it. It's prehydrated in sterile saline, so you can take it right out of the package and put it straight into the patient's mouth. There's no rehydration period for it. And it has a 12 to 14 month resorption time. But most importantly, it provides structural stability. And structural stability is what we really need for our ridge augmentation procedures. Let's take a look at how I use it. So you can see it bends. This is straight out of the packaging. Nothing else done to it. It definitely bends. You can fold it. You can do whatever you want to it. It does have memory. It's around 1 to 1.2 millimeters in thickness. And this is how easy it is to cut. Form it to exactly the shape that you want, just like you would any other membrane. It doesn't require anything else. It comes in 1 by 1 centimeter, 15 by 20 millimeters, and 20 by 30, I believe. And depending on the augmentation site, you use all three of those. So if it provides that type of stability, when do we really need stability when we're bone grafting? Well, a case like this, we need stability if we're looking at vertical augmentation. So in this case, this was before I knew how to use the laminar plate, but this is how I would treat it. This case has about 8 millimeters of vertical augmentation that is needed. So what technique do? I go to a titanium reinforced cytoplast membrane. Place my bone graft that's mixed with autogenous graft, place it in with screws, and let it heal for about 9 months. After 9 months, uncover it, and we're left with good, solid bone. There's no question this works. It really works. We gain 8 millimeters of vertical deficiency over here with a massive amount of bone thickness also. Gain that buccal shelf. Place the implant, have a lot of bone to the buccal, to the palatal, every aspect. So if that works, then what's the bad side? Well, exposure rates. What are those exposure rates? They range anywhere, 10, 15, 26, 52% exposure rates. And these researchers are in institutions. They're not seeing a lot of private practice patients like we are. So if they're getting these type of exposure rates where they see these patients really frequently, in private practice, you know the rates are higher. So if we can use resorbable materials that don't get exposed, then we're much better off. So can we do that? Can we get stability any other way? Well, let's look at Kathy. Kathy has a tooth number 7, maxillary lateral incisor, that obviously had to be removed because it was broken down. And you can see, looking at the site, of how deficient that ridge was. There really is only a little bridge of bone right at the crestal portion, which thankfully was there. So I use a rib roast technique, the periosseal suturing, to be able to stabilize the laminar plate over the ridge that was augmented. So place the particulate, place the laminar plate right on top of it, and use this periosseal stabilizing sutures to hold it down. Now there is that portion on the crest. What do you do with that portion? Bio-Exclude. It's the perfect material to be able to drape over it. Sometimes I just drape it over, and sometimes for larger cases, I'll actually tuck it underneath the membrane. Placing it before you suture is challenging to do, and so I rarely do that. I typically will place it after I suture down the laminar plate. So once everything is healed up, wait about 6 months, and then start the planning for the implant. It's a bit of a tight spot, but you can see over here, you can appreciate how thin the ridge was beforehand, and you can almost see where the graft was placed and the augmented portion of it. And then always know that you have that extra millimeter of the laminar plate that still can mineralize over time. How does it look clinically when you open it up? Just like this. This was one of the first cases that I used, one of the first ones that convinced me that, wow, something's happening over here. I typically open up augmented cases, and there's some granules, there's some bone flaking off. This was just solid bone. It's undifferentiable from the other bone. Place the implant into the ideal position, and I do a lot of these customized healing abutments to be able to start to guide the tissue and develop the tissue for the restorative doctor. And that's what I did over here, and placed a small connective tissue graft. And that little connective tissue graft, honestly, just take it from the palatal flap of this site. So all it is just thinning out the tissue on the palate of number 7 to be able to take just a small little graft. And that little thickness is going to mean a large, significant difference down the road. So if that works like that, what happens if you use it placing implants? It's always, this type of case over here where we have a slightly deficient site, and we're always thinking about, well, what do we do? Do we place the implant, graft around it? Do we do a ridge augmentation to be able to build the bone first? Those are thoughts going through my head all the time. So if we look at what I did over here, place my implant where I'm supposed to place it, but look at the buccal threads exposed. That's basically all the way down to the apex of the implant. I do have great stability, but I have no bone on the buccal aspect. So what do I do in this case? Well, it's not a big GBR, it's not a big rib roast, it's not a big sausage technique, it's not a big anything. Just really an envelope flap. All I did is raise the papilla around this implant and slide in a laminar plate under that flap. Once I do that, then I'm able to pack the particulate around the implant, between the implant and the laminar plate. And that's stable just on its own. The reason I'm able to do this without stabilizing sutures or screws or tacks or anything is just because of the minimal flap that was raised here. So it's stable. In this case, place a PRF and a Bio-Exclude over the crest and just suture it. 3 simple sutures. Implant, GBR, 3 sutures, done. This is what it looks like after 2 weeks of healing. And then after 4 months, hey, sometimes there's a problem, right? But if you're going to have a problem, what's the best problem to have? I can't find the implant. I'll take this problem any day. I don't know where it is, so I have to dig for it. So you do that. You dig, and you find the implant. And you place a healing abutment, 2 simple sutures, and it's done. So this is a deficient ridge, where I'm able to place the implant simultaneously, do GBR, can't find the implant, and be able to restore this very, very nicely. What about a bigger defect? Could this type of technique handle a bigger defect? Let's look at Seth, how I would treat it before knowing about laminar plates. So in this case, we're missing 2 central incisors, significant buccal deficiency, significant place my bone graft around it, and in this case, a long-term collagen resorbable membrane, and uncover it after 9 months of healing and get all the bone graft, all the bone growth all the way to the top so that it's even with the adjacent teeth. Place the implant, have it restored as a cantilever restoration. That's great. It really is good. But does everybody love placing screws? I don't, and they have a cost. Do you want to spend the screw money on every case? Well, let's look at another similar case used with the newer materials. So here's a case where you can see there's obviously an implant that failed and big, significant buccal deficiency, but also the palatal deficiency, just like the other one was buccal and lingual deficiency. So in my view, that's where it comes into play. There's not just a buccal deficiency, there's also the palatal. So with the palatal aspect gone, I know that it's going to collapse if I do nothing here. If I have nothing structural to support it, it's going to collapse on me. So I place the laminar plate. Here's the Bio-Exclude. You can see tucked underneath the sutures. And it's just to be able to provide more stability of the Bio-Exclude. Because if I just place it and then suture on top of it, there's a decent chance that it's going to move around. And sometimes it happens, sometimes it doesn't. And that's what really determines for me about whether I'm going to place it, just lay it on top of everything or tuck it underneath the sutures. But this is the standard rib roast technique, periosteal suturing. Let it heal, and 7 months later, it's all regenerated. And this is hard, dense bone. This is not a bone-like substance, this is bone. Place the implant into ideal position, and you move on for another day. Okay, well, what about an even bigger defect than that? That's a 1-tooth defect, right? 1 tooth. Anybody can do 1 tooth. How about 4 teeth? So this is Don. He's unfortunately lost his 4 mandibular incisors and has some ridge deficiency, vertical, horizontal, every which way of those sites, especially 324 area. And you can see over here how the ridge is deficient from the buccal aspect. Place my bone graft, same as before, same as every case over and over again. And here you can see I sutured the laminar plate and now overlaying the Bio-Exclude over the ridge. And this is what it looks like, almost like a saran-wrapped little gift where everything is tight and you can see how it's placed underneath the sutures to provide more stability. And this is how it heals. Everything 100% regenerated. So this is a case where I would love to say that I use a surgical guide, because in my view, I'm looking at this and I see one implant's a little more facial than the other. But thankfully, I actually did use a surgical guide, and I placed it into the ideal position. The teeth were going to be a little bit crowded. Okay, so what about even bigger cases? This is a case where ordinarily you're looking at a tie mesh, you're looking at, I don't know, any host of things, a large Corey if Dr. Hassan was doing it. And so I'm not as talented, and I'm looking to use my materials to help me. And so I use particulate allograft with 2 laminar plates that are folded over from the palatal to the buccal aspect. And I suture them down using the same technique. And overlay Bio-Excludes using the exact same technique. Suture it together, and you can see how this heals with just this massive mound of tissue. So how does that heal? After 8 months, this is the amount of bone that we have regenerated. Using a surgical guide, place my implants into the ideal prosthetic positions, exactly the way I wanted to do it. And that's the difference that we can make using strictly biomaterials. So there's no question that's a more maximally invasive technique, and that's a bigger site to graft. But what about minimal invasiveness? Here's a special case that tooth number 9 is being lost, and we have to figure out a way to be able to preserve everything for this guy. One of my favorite patients. I want to go all out for him. So Paul, take a look at this site. Deficient palatal, deficient buccal, through and through defect. There's no bone anywhere. History of trauma, multiple root canal procedures, multiple endodontic surgeries. A lot of junk in there. Sneak peek, this is where we ended up. So how did we get there? And it's really about reconstruction versus preservation. In reality, we can reconstruct, but we're never going to get to the same spot that where we want it to be, where it was at the beginning. Preservation is always better than reconstruction. And so if we do as little as possible using our materials, then we'll be able to preserve more than we can reconstruct. So let's take a look at how this is treated. So remove the fractured tooth and degranulate. And I can tell you, I was watching this video as I was editing it, and I know that I take a long time to degranulate. I didn't realize by the time I got to that point, there's 31 minutes. 31 minutes of degranulation using a microscope. So when you say degranulate, it's really degranulate. So if I thought about using the laminar plate in order to rebuild the ridge, it's really tough to slide that through the sulcus because there's no room there. So making a little vista incision really provides that access. And you can see that buccal deficiency, how I'm able to just tunnel all the way through into the socket. So slide it into that vista incision and then push it coronally to make sure that it's up there to build that. And there you can see right there. And now fill it with bone. And this is no autogenous bone. This is pure allograft. And tuck in a PRF membrane and a Bio-Exclude over the ridge. So completely deficient buccal plate, completely deficient palatal plate, and rebuilding everything. Suture the vista incision. and this is how he leaves that day. There was no papilla even elevated there. Ridge augmentation without elevating a single papilla. And it's only because I have a stiff laminar plate that I'm able to slide in through that VIST incision. Any other membrane would crumble on itself. This doesn't. So we wait some time, 6 months, and take a look at the regenerated bone, the regenerated ridge, where we started to where we ended up. Now I have enough bone for an implant. So let's go through some photos of how the next step was taken. So you can see the soft tissue profile of the healed site. Make a customized healing abutment and surgical guide so I can place the implant in an ideal spot. That same customized healing abutment I do to be able to guide that soft tissue for the referral. Place the implant. And again, used a little, you could see this was a tissue punch because the facial margin was in the ideal spot already. So I could do a tissue punch and I wasn't going to lose anything. But by doing a tissue punch, what does it do for us? It's extra tissue. Why not use that extra tissue to slide it under the facial, de-epithelialize it, and just slide it in as a connective tissue graft? Connective tissue grafts don't have to come from the palate, as my good friend Brad Ross showed a few people yesterday. Grafting doesn't have to come from the palate. This is just slid underneath the facial aspect just to thicken the tissue. Place a customized healing abutment to best guide and preserve the contour. And that's healing after 3 months. You can see the development of that contour. And that's how the implant looks inside that bone. So we go from here, or we end up over here, and this is a type of, look at the facial contour here. The amount of deficiency that we had, there was no buccal plate, there was no palatal plate, there was no papilla raised in this procedure. To be able to rebuild things only by using the membranes to their advantage, using our materials with their individual structures to our advantage. And by using the two of them together, if we look at the sort of best duos in history, right? Am I missing anything over here? I'm kind of partial to Ernie and Bert, or the two guys from the Muppets. But if you look at the best duos in history, I don't know, these two together have really changed my practice and been able to really combine using them together. And I've done case after case after case after case, maybe 50 cases by now, of using these materials in combination to be able to regenerate deficient ridges. And I have to tell you, this has completely changed how I view things when it comes to ridge augmentation. So that's my story. Happy to answer any questions you might have. Sure. So I tried to do it. I tried to use a screw one time as a Corey style, and it splits. So it does work. You could do that. You just have to be prepared that if you do it towards the edge, it'll split and you won't be able to retain anything. So you got to do it in the middle. I have not tried to tack it. I think you're going to have a hard time tacking it because it's 1.2 millimeters thick. It's not like a collagen membrane that you can just tack into the bone. You might lose your screw unless you use a 5 millimeter screw instead of a tack or something like that. But you can try it. But then you're going towards the edge and it'll split on you. Good question. I have started to use it. I wanted to see what it will do in a ridge preservation site over the top. And I did one which was really slight slightly exposed, it was like a canine or something, and pull the tissue, it was only a couple of millimeters exposure, and it did fine. But I haven't done it on molars or anything like that to be able to see how it really heals when it's completely exposed by 7, 8 millimeters. That is something I'm interested in also.
Do you find that the membrane itself is going to turn into osseous?
If it's going to turn into anything, I would imagine it turning into bone, but I don't have that type of long-term follow-up or studies to be able to back that up. I have not re-entered a site after a year plus or anything like that to see it, but I imagine it would end up turning into bone. It's just demineralized bone. So, yeah, it's like its own graft.
What's the shelf life on there?
I don't know. That's a good question. Bless you. What's the shelf life? 3 years only. That's it. Because I don't often place the laminar to cover the occlusal aspect. So typically the occlusal aspect is particulate bone, and I don't want them escaping through the incision line. There are times where I'm able to trim it and fold it so that it almost tucks under the lingual or palatal aspect. There are times when I do that, and in those cases I don't use a Bio-Exclude with it. But if I just fold it over and there's an area of just particulate, then I use the Bio-Exclude. Good question. I think those were, they must have been 2 15 by 20s. Essex, and she was not happy about it.
And that was 7 months in Essex. How many did you make?
So thankfully, I didn't make any of them. The restorative doctor made them. But yeah, it was probably 3 of them. Yeah. She was missing so many teeth that what other option is there? There's no bone in the premaxilla. It's too long a span for a fixed bridge. She didn't want removable. It's hard. Yeah, thankfully. Dr. Hassan?
I'm lucky I get to watch these in the practice.
All right, well, thank you.